All right, welcome back everybody. I hope you guys enjoyed your lunch, so now it's time to start with the afternoon sessions. I would like to invite our first speaker, Dr. Jared Robbins, who will be talking about improving outcomes for head and neck radiation therapy with IMRT.
Thank you. It's a pleasure to be here with you today, and it's been fun the last couple of days to work with some of you on contouring and going over head and neck cases. Certainly that's the fun part about what we do, to always have opportunities to talk about it. So today I'm going to talk a little bit about how we can advance head and neck cancer using IMRT. I don't have any significant disclosures for this. Technology has really improved the way that we deliver radiation. Historically, as you all know, using 2D, 3D fields in the head and neck area caused a lot of toxicity due to the amount of normal tissues that received radiation, and then those changes over time that cause a lot of suffering for our patients. With IMRT, we're able to improve the dose distribution, so we get better coverage of our tumor volume, which can lead to better tumor outcomes and oncologic outcomes, but then we also get better sparing of the normal tissues to reduce the side effects. And then overall, patients have a better quality of life. So on the bottom here, pretty standard view of a 2D field where kind of everything's getting dosed, to the 3D conformal where we are starting to avoid some dose. And then with IMRT, where the dose is more where we want it to be. So, in which ways does IMRT help improve our radiation-related toxicity for head and neck cancer? So there's quite a list here. Not all of these have been in a phase 3 randomized trial, but we know that these do help. So the first is, sparing the mandible to prevent osteoradionecrosis. We can spare the parotid to reduce xerostomia and even a development of caries later. Submandibular sparing to reduce xerostomia. Oral cavity sparing to reduce mucositis and dysgeusia. Larynx sparing to reduce aspiration risk and voice changes. Cochlea sparing to reduce hearing loss. Pharyngeal sparing to reduce dysphagia and aspiration. So there's quite a list of different things here, so lots of different targets to try to avoid as we plan our radiation. But of that whole list, there's actually only 2 things on there that have been shown on level 1 evidence, so randomized controlled trials where radiation does make a big difference. And that's with the PARSPORT trial for parotid sparing and the DARS trial for dysphagia sparing. So we'll talk a little bit about those. So as an American radiation oncologist, the PARSPORT trial is one of my favorite because it makes it so that I don't ever have to ask for prior authorization to do most head and neck IMRT. Some other sites struggle a lot, but because of this phase 3 evidence, it's easy for me. I just say, head and neck, and we get approval for IMRT almost every time. But this was done mostly in England. It was pharyngeal squamous cell carcinoma, mostly of the oropharynx and hypopharynx. Everywhere from T1 to T4 with N0 to N1 or N3. It was a randomized trial, so it was 7 patients in each arm. So it was IMRT versus 3D, and so the IMRT was optimized to reduce the dose to the parotids. The primary endpoint in this trial was the proportion of grade 2 plus xerostomia by the Lent-Soma criteria at 1 year post-treatment. They also did some other things. So they measured the saliva flow, they looked at quality of life, tumor control, progression-free survival, and overall survival. And again, like their whole purpose in doing IMRT in this setting, it wasn't to improve the tumor control or anything like that. It was really just to spare dose to the contralateral parotid. So a mean dose of less than 24 gray is what they went for. They had done a lot of pre-work before, and they tried to do a 5-beam IMRT for most of these, just to make it so the patient weren't on the table for too long. And here are the results. So there's a clear benefit, as you can see. This is grade 2 plus Lent-Soma subjective xerostomia. It's the one thing I like about this is over time, the IMRT continued to improve, whereas the people who were treated with 3D, they were kind of stuck where they were at. To me, suggesting that maybe there are some long-term changes that happen because of some sparing of the parotid. This is just a table where they compare the measurable salivary flow with the subjective xerostomia that patients experienced, and there was correlation there. And then I think the final thing, whenever we talk about changing our treatment a little bit to save a toxicity, we also want to make sure that we're also treating the tumor. And clearly there was no difference in those two curves. So we get the proper protection of the salivary function without loss of good tumor control. The second trial that I want to talk about came out recently. It was published last year. But the aim of this trial was, it was IMRT versus IMRT, but they were going to do, so DO stands for dysphagia optimizing IMRT. So the goal of this was to prevent long-term swallowing complications. So they used the standard IMRT plan where they didn't look at the pharyngeal constrictors, and then the other group was randomized to save dose to the pharyngeal constrictors without compromising tumor control. Again, this is a phase 3 randomized trial, mostly done in the UK. This was 112 patients, 56 on each arm. Again, pharyngeal squamous cell carcinoma, oropharynx, and hypopharynx. For this one, because they were sparing dose to the posterior pharynx and the pharyngeal constrictors, they did exclude patients who had posterior wall involvement, post-cricoid or RP positive nodes, or patients who had underlying swallowing difficulties up front. And their primary endpoint was the MDADI score at 12 months. And with theirs, their goal was to prevent dose to the medial or the pharyngeal constrictor to get the mean dose less than 50 gray without compromising tumor control. And so this is kind of how they did it. So if you can see right here, so this is the GTV here. Then this big red is the CTV. The yellow here is the pharyngeal constrictors. The blue is their elective nodal coverage. And so this is their initial contour, and this is how they would have done for the non-optimized plans. For the optimized plans, the part of the constrictor that was within the CTV, they excluded it. And then when they made their plan, they optimized it to avoid dose to this part of the constrictor, which you can see over here where there's the dose to that constrictor is significantly less. And so after over 3 years of follow-up, they did show that the median dose to the superior constrictor was reduced in the optimized plan. And it was even greater reduction to the lower part of the neck. So the inferior constrictors had a much greater reduction in dose. These are the differences in the MDADI score. That's probably seen a little bit better graphically. So you see at the different time points, the changes. I think of the ones on the bottom, probably maybe the easiest to see. But again, you see a clear difference in the MDADI scores over time. Again, on the green over here shows the difference in oops, wrong button. The difference in outcome. And you can see again that difference gets better over time. So, we always worry about the late toxicity, and I think this is where we're starting to see some of that come through. If we are able to spare normal structures, in the long term, we do get better outcomes. So, I wanted to review these with us because I think this does show us that in randomized control evidence of improvements with IMRT, and I think it's not hard to think that, these things that we do to reduce toxicity, as long as we're controlling the tumor, I think they will have long-term quality of life and also potentially functional and survival benefits by people able to do better. Again, looking at the cancer outcomes, they were even in both groups again, so we were able to effectively achieve the dose to the pharyngeal constrictors, which translated into improved outcomes as far as swallowing, but we didn't give up anything on our cancer control. So this is a graph that's a few years old, but this is the utilization of IMRT in the United States. So in a 10-year period, we went from maybe 5 or 10% utilization to pretty much 100% in just a short time. And this is a big time for research, of course, but also a time where people were doing the best that they could. There weren't a lot of guidelines out there to help people as they started to implement IMRT. And so I think it was an exciting time, but also a complicated time, and we'll talk a little bit about that. So as I thought about that, I kind of started to try to find some research about where we were at in Africa as far as IMRT utilization. And so the numbers that I found, I think, are under of what I've experienced talking to all of you the last couple of days, which I think is great. I think you guys are on the steep part of the curve where more people are having opportunities to use IMRT. But the data that I found, a couple of survey results, but they reported about a 30% utilization of IMRT. And they also talked about some of the limitations, and some of this was that they didn't have CT simulators or linear accelerators, or they had other things that were gaps like in-room imaging or multi-leaf collimators. Some of the gaps were also physics-related. IMRT is resource intense, and so you do have to have imaging and detectors and the QA and the software to do that. And then the other thing, which hopefully we can help with forums like this, is the training, getting people an understanding so they can feel comfortable using IMRT effectively. A survey from South Africa of state institutions reported about a 20% use of IMRT. And again, I think we're above that now, but that's where we were a couple years ago based on these publications. So the question is, as more and more centers in Africa have access to IMRT, how can we ensure that they maximize this technology to help their patients the most? There are some pitfalls as we transition into new technologies. So some of these, there can be great variability between providers and institutions. IMRT is very conformal. So if we try to be too conformal, we may miss the target and we may do worse for our patients. As the US was going through our rapid ramp up of using IMRT for head and neck, there were commentators that said, we've been able to spare toxicity more than ever before in head and neck cancer patients, but you've also never had a higher chance of dying from head and neck cancer being treated because of just some of those uncertainties and the lack of clear guidelines on how to treat and use these techniques effectively. But I think IMRT does put great responsibility on the providers. It takes a little bit more time to produce the plans, do the contours, review the constraints. It also is a bigger responsibility on the physics crew and the team treating it to make sure that the patient's QA is done well, that they're setting up well on their treatments. Someone before used where there's great power, there's great responsibility, and I think IMRT has that same, I think you can say the same thing about IMRT. With IMRT, we do have to have an intimate understanding of the disease processes. We have to know what to treat, we have to know what to avoid, and we have to know when we can push a little bit harder. The balance between tumor coverage and toxicity is one that's hard to maintain. We do always want to make sure that we're covering the tumor, but when we can do that and spare the toxicity, I think that's where we find our greatest successes. As I've kind of alluded to, IMRT is time and resource intense. So just to kind of show some of the treatment variation of the United States, or actually this is multiple centers, but these were 20 centers who were claimed to be head and neck IMRT experts. They were sent out some GTVs, as you can see here. So we have a GTV and a node and a GTV primary. And the goal that they asked for these people was, you have your GTVs, we want you to create CTVs and PTV recommendations and then send it back to us and we'll compare what people did. And so you can see here 9 of the different variations. So we have everything from ones that had plans that had just 2 dose levels that are unilateral to ones that have 3 or 4 different dose levels. Quite confusing and certainly not very unified. So it's hard to say if IMRT was working in this setting because the setting and the situations for all these was different. There was some consensus, as you can see from the table over there. Everyone covered level 2 and level 3 100%, but then after that, there was a lot of fall off between groups. The one thing too, it did take about 2 hours of contouring time for them to do this, again, showing that burden. So, how do we unify treatment and make it so we don't have 9 different ways of doing IMRT? So without standards, it's difficult to improve how we treat. One thing that I think is very helpful is clinical trial enrollment. If you go back to the PARSPORT trial, one of the things that they did, because they were early on in this setting, they did set very clear recommendations on how to create the volumes, what to treat, what constraints to follow. And so it was a lot more unified than the 20 different groups that submitted contours for that project. That reference is here. A little bit outdated at this point, but it was nice to see how they started out. Since that time, there's been a lot of guidelines and atlases that have been developed to improving our contouring and improving the outcomes with IMRT. These are just a couple of them. So first, when we start an IMRT program, I think we do have to make sure we're all speaking the same language. One of the ways that we do that is understanding how we create our elective tumor volumes and how we name them. So this paper by Gregoire goes through and breaks down all the head and neck levels into nomenclature that we can all recognize. And be able to talk to each other in the same way and treat things reproducibly between centers. Once we understand what are our targets, it's also important to understand what are our organs at risk. And I think the organs at risk for head and neck, there's a lot of them. They take a long time to make sure that they're right. But taking the time to ensure that they're right does have big impacts on our patients. And if we're not contouring them consistently, it's really hard to know if we are sparing the parotid glands or if we are sparing the constrictors because of the way, if they're not contoured correctly, we may be off. And we tend to put a lot of weight in those DVHs and isodose lines, so we want to make sure that they represent the appropriate things. And again, this atlas sets a nice standard for that. I don't want you to spend a lot of time reading this, but basically this just shows another international guidelines for nasopharynx and how it's changed over the last really 1.5 decades, and how it's evolved to do better and better at identifying the tumor and covering the proper areas. But so there's a lot of resources like this. I think Dr. Beadle put together some of those resources and we're going to send them out, so they will be available for you. I do think the other thing as we start IMRT, it's good to go back and look at your experiences. I think it can refine what we do. So this is from a University of Michigan's early experience, but I think it's one of those things that I think shapes some of the way we do things now. But so in their early experience, they went back and looked at what they were doing. This was very much in the time where there weren't any guidelines, so they were just doing the best they can to take the 3D volumes that they've been treating and to create an IMRT plan for that. And what they noticed as they reviewed that there was an excessive number of ipsilateral recurrences in the high-level 2s or the retrostyloid space or in the retropharyngeal lymph nodes above C1. They were contouring to C1 at that time. And so they changed their practice. They decided to start covering higher to the base of skull on the node positive side. And after they did that, they saw that the number of recurrences went down. Likewise, on the contralateral upper level 2 and retropharyngeal nodes, they noticed that they could spare that effectively and spare the parotid gland without having an increase in the nodes. So this is kind of what those volumes might have looked like, where on the opposite node negative side, you are able to not go to the base of the skull, whereas on the node positive side you are. And then by doing this, they could spare some of the pharyngeal constrictors and also the parotid gland. The other thing we learned from is from marginal misses. So this was a paper by Alan Chen looking at their experience. And I think when we know we can spare a gland like the parotid, we try to press as hard as we can to spare as much as we can. And this kind of shows that sometimes we might be misguided when we do that. So this is a study where they went back and looked at 305 patients. The first half of them or so were treated with an intentional parotid sparing on the ipsilateral node positive side. And then the second batch was treated with deliberately without sparing the parotid on the ipsilateral positive side. And so what they showed was that the 2-year outcomes of spared versus non-spared was that there was a difference in the overall survival outcome and also the regional control due to recurrences in and around the parotid in those patients that probably had too much sparing. And when they went back and looked at it, their spatial evaluation revealed significantly higher incidence of marginal failures or true misses in the cohort that had IMRT sparing the ipsilateral parotid in a node-positive patient. And so this just shows one of those cases. So you can see, and the lines are really hard to see, so I'll try to draw them. So this is the PET scan with the dose from the treatment overlaid. So this is the recurrence here. And if you can look close, you can see that the isosceles line is curved to the inside here. It's a little easier to see here maybe. So you can see how it curves in here. So about 30% of the recurrence wasn't in that treatment volume, and that's probably what led to this recurrence. So I think this is good to point out so that we know that yes, we can do a lot with sparing, but we also want to make sure that we're protecting the areas that are at highest risk. The Kaplan-Meier curve there just shows the difference in progression-free survival, showing that there was a difference due to these misses. The other thing we have to do as we learn and use IMRT more and transition from 2 and 3D to IMRT, we have to know what we're treating and why. When we treat everything, like with large fields, we didn't have to think much about which levels could potentially be involved, and now we do. So having an understanding of that knowledge is really important. And so the areas that do have a low metastatic risk can be spared. Some of the things we can look at to get some of that data is our surgical colleagues. Then we have pathology to make sure that it is really true. And so this surgical data from Hopkins looking at HPV-positive oropharynx tumors that were treated with surgery showed that there's a really low subclinical disease risk in level 1B and level 5, while level 4 has a little bit higher dose, or a little bit higher risk. The level 1B subacute involvement does exceed 5% if you have multiple lymph nodes involved. So again, it's not always that you can spare some of these spots. You have to look at the bigger picture. The risk of occult disease in level 4 tends to be about 5% if level 3 is not involved. So things like this can help us. This was a table that one of my residents and I put together looking at studies that reported which lymph nodes were involved for oropharynx tumors. And the green box kind of shows level 2 and level 3, both ipsilateral and contralateral, are the areas that are high at risk, whereas 1Bs, 4s, and 5s have a lower risk. And these all tended to be earlier stage patients. So if you have a patient that has a large invasive tumor, I think you can't really trust these numbers. I think these numbers will be higher the more advanced the disease is. Just to show kind of the importance of the primary site and the volume of disease in the neck with what lymph nodes need to be covered, I did put in the elective coverage from a new NRG trial, HN009. And this just shows the primary site, and based on the primary site and the degree of nodal involvement, the different levels it should be covered. So the extension to the soft palate or the base of tongue does make a difference for a tonsil cancer. The difference between a larynx cancer that's involving the hypopharynx or strictly in the larynx is important in your nodal coverage. So I'm out of time. I enjoy talking about head and neck too much, but again, this is just another retrospective series showing that you can sequentially work on reducing your volumes, and if you do it in a systematic manner, you can do it safely. So IMRT does provide outstanding tumor coverage. You can do a lot of neat and amazing things. You can do crazy cases like this where you cover the scalp and the neck. You can do extensive P&I. You can do base of skull. You can do some reirradiation safely. But it does take effort to put into it to make it work. And I'll conclude there. Thank you very much.
Thank you, Dr. Robbins. Next, we would have Dr. Claire Umubyeyi, and we'll be talking about head and neck cancer case presentation.
Good afternoon. I'm Dr. Claire, a clinical oncologist from the Rwanda Military Hospital. I'm going to present a case that we treated 2 years ago with oral tongue squamous cell carcinoma. It's a 64-year-old male patient. He was a lawyer, and he presented at a hospital called King Faisal Hospital in the ENT department in Feb 2022. And his main chief complaints were tongue pain and non-healing ulcer on the right lateral surface of the tongue for around 3 months. So he didn't have any history of smoking. He had a history of alcohol consumption, no past medical history. He was divorced and he was living with his girlfriend. When he was examined, he had a right lateral tongue tumor and right cervical lymph nodes. So a CT scan was requested for neck and chest, and it showed an ill-defined and heterogeneously enhancing lesion at the right side of the tongue, and it was not involving any adjacent bone, and it was measuring 4.5 centimeters with bilateral multi-level mildly enlarged lymph nodes. The dominant was seen in the right level 2B, and it was measuring 2.2 centimeters, and there was no distant metastasis. So it was staged as a T4A and 2C M node. A month later, he underwent a partial glossectomy with right selective neck dissection. Histopathology came out as squamous cell carcinoma, conventional type grade 2, PT3 and 2B. The largest tumor dimension was 5.5 centimeters. LVI, PENA, ENE were all negative, and all margins were also negative, with the closest margin being in the medial, measuring 4 millimeters. 2 out of 11 lymph nodes were positive. Then he had a wound that was well healed, and he was sent to our center for adjuvant radiotherapy. He arrived after 7 days. He was reviewed by an oncologist, and he had a good performance status, ECOG-1, and there was no lesion on the tongue. The surgical wound had healed, and there were no cervical lymphadenopathies palpated. So we requested for a control CT scan, and it showed post-surgical changes in the tongue, no residual tumor, but multi-level bilateral cervical lymph nodes, more on the left than on the right, and the dominant was seen in level 4, measuring about 1.5 centimeters in short axis. So we prescribed radiotherapy, and the patient was booked for CT simulation. But the patient disappeared, so he didn't want to come back. And 3 months later, he then agreed to come back and agreed to come for radiotherapy. So on the history, he said he had, in fact, the reason to why he came back, he had a new lesion on the tongue, as well as on the left neck, and he again went to his ENT surgeon who planned surgery, but he had a cardiac arrest on table during anesthesia, and the surgery was aborted. So we had to recounsel the patient and requested for urgent simulation. And after simulation, we went for delineation 1 day later, and we observed that he had a bulky disease, more on the left side of the neck, and he had been simulated with a tongue depressor. And so we, at that time, we had to discuss with the team, and we decided to consider induction chemotherapy and then resimulate. So he went for chemotherapy. By that time, carboplatin and paclitaxel was the chemo that was being offered to all head and neck cancers. So he received 4 cycles. The reason to why he received 4 cycles is that we didn't do the treatment the time we had planned because we had machine breakdown. And so they had to continue, and he received 4 cycles. Clinically, he had, I can say he didn't have any response to chemotherapy. He had peripheral neuropathies and difficulty feeding. So we examined, and he still had a left neck node with submental and some submandibular fixed mass. He had refused to have feeding gastrostomy. Then we had to recounsel the patient, and he agreed to have a percutaneous gastrostomy tube inserted, and we again had to resimulate. So the patient was treated with radiotherapy, 70 gray in 35 fractions with concurrent chemotherapy, but he received only 1 cycle of cisplatin and then another cycle of carboplatin due to progressive kidney impairment. He had his GFR going down, and he could not tolerate the chemotherapy. Even with carboplatin using area under the curve of 2, he was not tolerating it. So he received the last fraction on 8th Feb 2023 with a significant clinical improvement. The left neck node had disappeared, and he was remaining with a wound with necrotic tissues, dry skin desquamation, grade 2 oral mucositis, and xerostomia. So the patient was discharged, and he was planned to be reviewed after 4 weeks for follow-up. So the technique that was used for radiotherapy, he was treated with radiation using VMAT, and the prescription was done to the primary and involved lymph nodes, 70 gray in 35 fractions, and we gave bilateral high-risk elective nodes, 63 grays. And he was simulated in supine position with neck extended, shoulders were down and immobilized with a thermoplastic mask, and bolus was put on the left neck. These are the target volumes, where the green shows the tumor and the involved nodes, and the gray the elective nodes. This is how the DVH looked like. So he came back after 3 months. After 1 month, and he could swallow some liquids, but not normal diet. He was complaining of on and off headache, and difficult opening the mouth, and he had reduced appetite. His ECOG was going down. He had the left wound was healing, and he had no new lesion. So we advised on adequate hydration, a lot of water, and then we asked him to come back after 3 months. Unfortunately, he had multiple consultations, and he was hospitalized for nausea and vomiting. He had progressed generalized body weakness, treated for sepsis. The left wound had left neck wound had infection, and he had recurrent AKI and electrolyte imbalances, and he died 3 months after completion of radiotherapy. So when I went through the case, and I was thinking what was wrong, these are the few points that pointed out. He had poor nutrition throughout the treatment. He had poor adherence to the given appointments, and he didn't have adequate counseling, so we delayed to start palliative care. We had unnecessarily overtreated him. We exposed him to unnecessary toxicities, and we ended up delaying the definitive treatment in an aggressive and bulky disease. And I also thought he had inadequate surgery. So I would have loved to hear from the audience what they would have done differently, and what they think went wrong. Thank you. This is the end.
So if anyone has any questions or suggestions for Dr. Umubyeyi, we can take one comment right now, or maybe we can talk during the break. Okay, so let's keep on moving. Thank you, Dr. Umubyeyi. Next we have Dr. Sonia Worku, and she'll be talking about impact of radiation interruption in head and neck cancer.
Good afternoon, everyone. I am Dr. Sonia from Ethiopia, Black Lion Hospital. Yeah. I am from Ethiopia, from Rwanda Specialized Hospital. I'm going to talk about the treatment interruption in head and neck cancer. This is history. That means our history, based on our history, you will learn something or take us a lesson from us. Rwanda Specialized Hospital is the first and among the third radiation therapy center in the country. Head and neck cancer is the third most common cancer treated with radiation in our center. Since 2020, we implemented the LINAC, or Advanced Radiation Therapy Techniques, and all head and neck cancer patients were treated with IMRT and VMAT. I have two cases to show you us an example what we were treating these patients and what was wrong with that. The first case is T3 and not M not tonsillar CA. This is a GTV, and we were treating this patient with IMRT, and this is the coverage. The dose color was 95% of the PTV. The problem was this at that time. It means, as you see from the figure, after 13 fraction, the patient discontinued his treatment for more than 30 days, and he restarted the treatment 14 fraction after 30 days of interruption. The second case is nasopharyngeal CA patient. It's T2N1M0. We prescribed definitive concurrent chemoradiotherapy for this patient. This is the GTV, node and GTV primary. This is the CTV, the three CTVs, CTV 17, 59, and 54. We were treating this patient with VMAT. And this is the coverage. You see how much it's conformal. And the next problem is there is still, in this patient, there is still an interruption. After 5 fraction, there is an interruption in between. Then he starts the 6th fraction after 32 or 28 days of gap. So despite the improvement in radiation technique, there is an unplanned treatment interruptions, and this makes our treatment, the outcome of the patient less optimal. And one local evidence was conducted at that time in 2023. In that study, they investigate the treatment pattern and outcome of head and neck CA patients. In that study, they were reported 48% of the patients were died. So when it came to today's schedule, the unscheduled interruption in head and neck cancer can significantly impact local regional control and overall survival. We all know this, but to be evidence-based or to present our experience, I'm going to present our investigation. We conduct a retrospective study in 126 patients to investigate the occurrence, the cause, and the impact of these interruptions in our center from 2021 to January 2024. In that study, what we found was the median age of the patient was 48 years, male were predominant, and nasopharynx is the most common, followed by oral cavity and larynx. 90% of the patients were presented as a local advanced disease. From this, 53% of the patients received definitive radiation therapy, only 36% received concurrent chemoradiotherapy. This is the baseline clinical and histopathologic characteristics of the patient. In this study, what we found was almost 82% of the cases received their treatment with interruptions. 80% of the patients received their treatment without interruption. The average interruption duration was 8 days. From this, around 50% of the patients, the interruption was less than 5 days. And when you see the cause of the interruption, radiation machine breakdown is a major cause of interruption. And the second is holiday, but the radiation-induced toxicity is not much, that much a cause for the interruption. When you come to the compensation for the interruption, less than 1/3 of the patients who were compensated the interruption by giving Saturday treatment. Otherwise, all the other patients complete their treatment with extended period of overall treatment time without the dose escalation. This is the overall treatment time. The median overall treatment time was 49 days, and at 6 patients, that means it's 3% of the patient, the overall treatment time was 56 days and below. From this patient, almost 60.1%, the interruption was 49 to 56 days. That means still there is extended overall treatment time. When you see the overall survival, this is the overall patient overall survival after 30 months of follow-up. The overall survival rate was 62%. When you compare the interruption versus the non-interruption patient, the non-interrupted radiation received patients, the survival is 3 times higher days rate in the interruption group than that of the non-interrupted group. Around 29% of the patients had a treatment interruption more than 7 days. We will compare this interruption with survival. Those who discontinue their treatment more than 7 days and less than 7 days, the survival rate is, there is a difference, around 5 months difference in survival. This is not helpful. As a conclusion, the study reported that there is a higher rate of interruption, around 82%. This is exceeding the global range of interruption. Patients who experienced interruption had a higher rate of days than that of the non-interrupted group. As a recommendation, all efforts should be made to minimize or to prevent the treatment interruption, and at the same time, all interruptions should be properly compensated, not only on Saturday treatment, but you have to use other compensation mechanisms by calculating the BED, escalating the dose, or by giving 2 times per day. This is what I have. Thank you.
Thank you, Dr. Worku. Next, we have Dr. Eleanor Walker, and she'll be talking about her experience with prostate cancer and breast cancer and her experience with Africa.
Good afternoon, everyone. Hope you're awake. There's coffee outside, and I will not keep you from it because I need it too. But let's see. Okay, thank you for inviting me to speak on this today. Radiating Hope is one of the groups that I work with, trying to help improve cancer outcomes in Africa. And so I'd like to talk about 2 projects that I've been involved with for several years. So I have no disclosures. And one is the Precision Medicine for Aggressive Breast Cancer Partnership in Africa. I hope a few of you from different hospital systems are involved in this. And the other one is a study that we did recently about integrating orthodox and traditional medical treatments in prostate cancer care in Ghana. So as we heard earlier this morning, globally, we know breast cancer is the leading cause of cancer across all age groups and sexes, with an incidence of 11.7%. And it's the 5th cause of cancer-related mortalities, 6.9% of deaths. And GlobalCon 2020 stats shows that among patients who are less than 40 years of age, breast cancer accounted for 17% of those, and 9.2% of cancer deaths in Africa. So although we know, generally speaking, breast cancer is a disease of older age, recently I think we've all seen the earlier onset of disease less than 40. And at a younger age, breast cancer is linked to more aggressive histologies, tumor biology, worse prognosis, and outcomes. So this is a paper that the International Breast Cancer Subtypes Group that I'm part of put out in 2019 about the hereditary susceptibility of triple-negative breast cancer with Western sub-Saharan African ancestry. And what we saw was that triple-negative breast cancer was highest in Ghanaian and African Americans with a P of 0.0001. It was highly significant as compared to the lowest incidence in Ethiopian and white American cases. And the triple-negative cases had higher West African ancestry than non-triple negative, and there was the frequency of the Duffy null allele, which was something that we found a few years ago. And it's an African ancestral variant that under selective pressure we found, such as protection against malaria, seemed to be expressed and was associated with the triple-negative breast cancer. And so more commonly found triple-negative breast cancer in African Americans, and Ghanaians in general. Additionally, there were 2 other alleles that were found that were also associated with overall breast cancer risk and significantly associated with triple-negative breast cancer risk, although none were as strong as the Duffy null variant. So our conclusions were that West African ancestry was strongly correlated with triple-negative breast cancer status as well as germline variants related to breast cancer. And the Duffy null allele was associated with triple-negative risk in our cohort. In addition, we did find that there was some association with prostate cancer also. So the other group I work with, Precision Medicine for Aggressive Breast Cancer Studies, looked at 2,418 Ghanaian breast cancer patients across the country. And what they looked at was the age of early onset breast cancer versus later onset. And it found that the median age for young onset was 34.66 years, which was about 20.2% of the population, the study population. And that triple-negative breast cancer occurred in early onset as compared to later onset, and there was a higher burden in these women who were younger. And also it confirmed the more adverse clinical and pathologic features of early onset breast cancer. So the information from this study suggested that studying a cohort of these earlier onset breast cancers would give us more molecular genetic insight into the biology and help improve treatment and care for people all over. So this is I just put this here, I know it's a lot of writing, talking about the work, the paper, the citation if you were interested in looking at it. So actually, because there's a huge need, we know, for capacity building in both the basic and the translational research in sub-Saharan African, over the last 3 years, we've been training clinicians and researchers across Western Africa through our annual training workshops. And the partners and researchers across sub-Saharan Africa study together on these breast cancers. So for the first time, we're actually having a workshop in East Africa, in Tanzania, and it will be at Kilimanjaro next week. And it's hands-on training and intercontinental networking. And this is just showing what we're trying to do is train the pathologists in sub-Saharan Africa even more. And for those of you who can make it, who are in the area, the conference is actually free. So you can attend for free. There is funding. You might want to participate in it next week, Thursday and Friday. And this is just a picture of some of our different conferences that we've had in Ghana, different parts of Ghana. So, and the people that have worked with us together both on the continent and in the United States. So, this is one of my favorite pictures, and it's to help me transition to the study I'm going to talk about in Ghana on prostate cancer. So this is generally a physician in the United States whose patient is diagnosed with cancer, and they come to the physician and said, oh, can I use some alternate form of treatment? What works? And we, in general, have no idea what to tell them. So I use this to introduce the concept of how we can handle this. So indigenous traditional medicine, which is a general term that the World Health Organization uses, and it defines this traditional medicine as the sum total knowledge, skills, and practices based on theories, beliefs, and experiences indigenous to different cultures that are used to maintain health, as well as to prevent, diagnose, improve, and treat physical and mental illness. So if we can understand the ethno-medical traditions across the diaspora, we can bridge the gap between health belief models and cancer care. But in order for the integrative oncology community to deliver culturally appropriate care and prioritize integration of traditional medical practice with conventional medicine, we have to understand the foundation of the healing practices across the world. So, integrative oncology is defined as the synthesis of mainstream care and non-pharmacologic, evidence-based complementary therapies for the control of cancer-related physical and emotional symptoms. And it is the symptom control arm of our cancer supportive care. It addresses the physical and the emotional problems that patients may have. It's attentive to the family as well, and it allows a patient to feel empowered and accept some individual responsibility in their care. And it could potentially reduce both cancer recurrence and second primaries. So we were able to obtain a Pfizer global grant about 2 years ago to study integrating orthodox and traditional prostate cancer care and treatment in Ghana. And because we know, as was noted earlier, prostate cancer is very high. Really in the US and in Ghana, we see very high rates of prostate cancer. And there's a prevalence for the patients to present to orthodox or conventional medical practitioners when they're in the later stages. So we want to identify and address the barriers contributing to the delay in seeking orthodox medical care. So to address the problem of delayed presentation of these patients to the hospital, which led to decreased and to ultimately decrease death among these men, we used a multi-stakeholder, multi-level approach to identify their address their beliefs and practices. So to identify the barriers and reasons, we had 3 groups in our study. We had the patients who were from 40 years of age and older, we had traditional healers, and we had orthodox healthcare providers. So, as we know, these men went to the traditional healers first. So we wanted to see what people's beliefs and education was. You can see here, and I hope I guess I can do it this way. There were about 282 patients, 66 traditional orthodox health practitioners, and traditional healers. And what we found, this is hard to see from this side, so I can point it out, is that the patients, most of them had just a primary education, the next group was secondary, and then tertiary. The people who had the tertiary educations was the medical practitioners, but traditional healers really didn't have much education, which was an issue. And then, when we look at their knowledge about prostate cancer, there was not a lot of knowledge in each of these groups. It's hard for me to see from here, or here, because this is a little small for my eyes. But this gives you the information of what they knew about prostate cancer, what causes death, and what treatments. Also, looking at this other table here, We identified the barriers, such as, oops, and I hit the wrong thing. Okay. Okay, I think I'll go to the next slide because it gives you the reasons in one hit. So the reasons why Ghanaian men prefer traditional healers over conventional medical providers included cost. Cost was a big thing, and the lack of faith in orthodox medicine. Also, because of the significant gaps in patient knowledge and traditional healers, that was another reason. And given that trust that men have in traditional healers, we felt strengthening the partnerships, educating the traditional healers on what things to look for when they had patients come to them when they were in earlier stages, such that they were more treatable than in stage 4, was important. So I want to introduce this. I don't know how many of you are familiar with this group, Society for Integrative Oncology, of which I'm an inaugural member. This is the 21st year that we've had it. And our mission is to advance evidence-based, comprehensive, integrative healthcare to improve the lives of people affected by cancer. And so I didn't go all the way back to 2007, but I did put here for your information that over the years we've developed guidelines on how to use integrative medical practices to help improve cancer outcomes and support patients. The most recent one just came out in July, and we've done several of these in conjunction with ASCO, the American Society of Clinical Oncology, so that when your patient comes to you and asks about certain things, you have a reference to go to, which is evidence-based. And this is just showing you the guidelines. I know it's very busy and it's small, but just showing you for the latest guidelines on fatigue, anxiety, and depression, what things have been shown to be beneficial. And again, this is just showing you a card that you can get to have in your office so that you can reference it. And these are some of the papers that have come out in ASCO, in the Journal of Clinical Oncology, that you can reference to help discuss these different therapies with your patients and make a shared decision about the use during or after therapy. And that's another one, our latest update. And this is just a quote from one of our patient advocates who's actually on our board, and what it means to patients to have something like this available and to be able to talk to their physicians about it. Bert said, when I was diagnosed, my first question was, what else can I do for myself? Then I discovered SIO. I learned that there are many therapies and changes that I can make to improve my quality of life. Diet, mindfulness, yoga, exercise, and other therapies that have helped me live my best life. I attended the last conference in Banff. Actually, the last conference was a week and a half ago in LA, and have been excited for this year's conference. Learning how people are helping people with cancer to live better lives is inspiring, and I love that all the therapies don't involve pills or meds. So what is our bottom line with the role for integrative medicine, at least in the US? And I think it's very important to talk with patients here in Africa. My family is from the Caribbean. I grew up using integrative therapies to help with my health care, so it was a natural thing for me to want to incorporate it in when I talk with my patients about things they want to use. And once I bring it up or ask them about it, they're very open to discussing it and letting me know what they're using, so that if there's something that could cause an interaction, I'm aware of it ahead of time and can discuss it with them. So for integrative medicine, we know there's no systemic cure for cancer through any of the complementary alternative medical therapies, but patients do want to discuss issues. So they're confident when they say no to when their cousin says, oh, well, you know, I heard someone got cured from this or that. There are minimal scientific evidence available for survival advantage, but research is ongoing. Lifestyle change is very important and will improve population health. And supportive care techniques can improve symptom control and our patients' quality of life. And the desire for integrative therapies helps to self-empower patients to become an active participant in their cancer care. So I just want to thank you all, and if you have any questions later, please feel free to contact me.
Thank you, Dr. Woffer, for the wonderful talk. And it's time to enjoy a short coffee break. We can see you back in around 20 minutes time at 2:55.